Hello, everyone. Welcome to today's webinar on drugs, data, and defense. We're talking about protecting patient data while providing excellent patient care, and we're going to go beyond drugs. We originally gave this session at the Assembly of Specialty Pharmacy Conference, so if you were there in the room, some pieces of it might sound familiar, but we've made it even better. I'll tell you why in just a second. I'm Lisa Silverman. I am your facilitator for today. The reason we made it better is because in addition to our president and CEO, Dr. Shawn Griffin, we added our CIO, Maggie Cornett, who's a nurse by training, trade, passion, and love. And she's here to share the stage with Shawn today. Just to give you a heads up, here's our agenda for today. We're doing our welcome bit. You know, we do this. We're going to make sure that you know a little bit about URAC because some of you may be new to URAC. Shawn's going to talk about the basics of data types and access. Then Maggie's going to come in with her technical expertise here and talk about the risk factors. And then Shawn's going to close us out talking about how policy fits in. It's a great session. We want you to ask questions along the way. I've worked with Shawn and Maggie enough times on webinars like this. They know I'll interrupt them and they know that they'll interrupt each other. They're bringing their expertise to this virtual space for us for the next hour. Maggie, with that, I'm going to turn the floor over to you. For those couple of people in the room who don't quite know about URAC all that much, you're going to give the overview of who we are and what we do.
I am. I'm going to be quick, hopefully, and I can have the next slide, please, Lisa. So I've been very proud to be part of URAC for over 5 years, but URAC has celebrated past its 30 years anniversary. And obviously we've grown quite a bit over those 30 years. We provide a wide variety of accreditation and certification programs across the healthcare verticals. But however, I want to point out that throughout our 30-year history, URAC has remained independent. We don't offer consulting services. You don't pay to consult with us to gain our accreditation. Also, all of our reviewers are staff members, and all of our reviewers have a background and experience in the field that they're reviewing. In addition, on an annual basis, the URAC reviewers are evaluated to ensure that they score consistently between each other and across the programs. Next slide, please. Okay. I wanted to just give you a quick differentiation between what is a regulation versus an accreditation. As you know, regulation is typically set by either a governmental body or an organization that represents a constituency, and it sets the bar for safety. But what URAC does is go beyond that. It sets that bar for quality. Quality goes beyond. It's not only that basic safety, and many URAC programs contain the need to report measures. Quality improvement projects may be reviewed during your accreditation because, as we know, quality has no endpoint. It's a continuous process of rising and reviewing where you are and then seeking to achieve and go even further. Next slide, please. The standards and the elements of performance that URAC programs for accreditation or certification are built upon are built on that framework of quality. Our standards assist your organization on focusing on continuous quality improvements. Our URAC reviewers then serve as that independent third party to verify how you're doing and allow you, when you achieve accreditation or certification, to distinguish your organization from your competition. Once you achieve URAC accreditation or certification, the expectation is that you're going to maintain that throughout the period that you're accredited. And when you re-accredit or re-up your accreditation or certification, that you're going to have maintained that same level of quality focus over the entire period, not just the day that we show up at your door to do a validation review. Next slide. So as you can see, this slide goes into the breadth of URAC programs, and we cover a lot of the healthcare verticals: digital health, telehealth, remote patient monitoring. We have patient care and administrative management. So that's everything from utilization review, case management, all the way to health call centers and health websites. We have health and dental plan accreditation. We also have accreditation for parity for mental health and substance use disorder. Are the services you're providing from a mental health or substance use focus the same or equivalent to that same level that you do for your medical benefits? Next slide. And then going on, URAC has a number of programs, obviously in the pharmacy space. They range from specialty and mail service pharmacy to infusion pharmacies. And then we have new areas specific to pharmacy services, dispensing, drug therapy management, point of care testing. And then in addition to the pharmacy, to all of the programs we've talked about, there are designations that you can hold over and above your accreditation or certification. A designation such as rare disease designation or transitions of care doesn't stand on its own. It stands or sits on top of your achieved accreditation or certification. It's that added extra, it's the icing on the cake. And again, it helps to distinguish you as a center for excellence in those areas above your competition. And now I'm going to hand off to Shawn Griffin, MD, our CEO, and he's going to talk a little bit about the basics.
Maggie, thank you very much. I appreciate it. I just want to say a little bit of a shout out here. An organization like URAC, we are fortunate to have somebody like Maggie who brings just a wealth of knowledge and experience in the IT world. And anybody who deals with IT knows how important it is to have somebody good in IT who can translate for you all the technical stuff into, real people speak. And Maggie does a wonderful job of keeping us on the straight and narrow and keeping us safe when it comes to data and those sort of things. So thank you to Maggie. Next slide, please. So why this topic matters. When you think about data, what we are seeing is we are seeing more and more data flowing into the moments where care is being delivered. And that's because we're seeing things like risk. We're seeing things like really expensive medicines that have to be used appropriately and that sort of stuff. And the more data that you have when you're interacting with a patient or when you're delivering care, the better that care is going to be. I mean, it's certainly better to know somebody's medical history when you're talking about their medical present or their medical future, or the medications that they get from some other provider or some other pharmacy when you're looking for drug-drug interactions and those sort of things. So that idea, the top center box, more data is a more accurate understanding of a patient's entire health. And as risk and responsibility have gotten pushed to more people, risk-based payments, value-based payments, those sort of things, you naturally want to have more information. But when you have more information, you have more risk. And there's a couple different types of risk that we think about. There is the regulatory risk. If you have a data breach and all of a sudden all of your patient information is out there on the web, you know what? They're coming to probably fine you from the federal government because that's a HIPAA violation and you need to be careful about those things. But the other thing is that every day when I'm opening up my emails, I see things like, so-and-so has had a data breach and it's in the papers and it's almost like a scandal. How are you being willy-nilly with your data to where it leaked out onto the street and those sort of things. So there's the legal and the financial risks that go with that. There's also the reputational risk. Also, as an organization, very often you should have some type of insurance to insure against data leaks and data breaches and those sort of things. And with all the things that have happened with hacking, both state-sponsored and independent people and those sort of things, your cost of insurance, your cyber protection insurance has gone up over the years. So the better you keep things controlled, the less risk you have, the less you're going to have to pay for insurance, hopefully. And we've seen that organizations have talked to us and they've said things like, we're seeing our cost of cyber insurance go up 50% a year. And that's if you haven't made any mistakes. If you make a mistake, you might not be able to get it from the person who you used to get it from before, the company that you used to get it from before. And as all of this continues to expand, if you're a pharmacy, you're no longer just dealing with how to dispense the medications. You suddenly have new systems that come in where you're accessing the medical record or patients are bringing in their medical information. And every time you connect your systems to some other system, you pick up what we call partner risk, okay? You don't just have to worry if your people are doing something bad. There's people in other organizations who are connecting to your system. And if they have a bad person, they're going to affect your people. And it's a little bit like a contagious disease. It can just spread from one organization to the other as these people doing bad things, are trying to get more and more data. The other thing is that it's not just people who are doing bad things. Sometimes mistakes happen. Every once in a while, you'll see a story about somebody having a laptop that has patient information on it and they leave it on a bus or something like that. That was a classic story that we had in the Texas Medical Center when I was working there. So you have to think about all of those things. And in some parts of healthcare, they've been doing this for 20 years. In other parts of healthcare, this is new in the past couple of years, and you just have to get used to it. All of a sudden, you have to worry about, how often do you need to change your passwords for your person at your front desk, and how much information can they get to, all those sort of things. But not only that, but when you're using these systems and they're working well, and you get to where you're great with them, and it's just bringing you all this great information, what are you going to do the day that you go in and all of a sudden your switch to the internet is down and you can't access that information anymore? What are your downtime procedures? How do you train for that? How are you ready for that? And so all of these things sort of factor in about, who do you hire? How do you train them? How do you keep your data safe? How do you keep all the different types of safe that now matter about being safe? And if something happens, how do you handle it? Okay. If the power's down, how do you handle it? If somebody overhears a conversation, how do you handle it? And how do you hire the right people and give them the right credentials to do the right part of their job and not have them get too much? I remember a story from a couple of years ago where somebody famous was in a hospital in Los Angeles, and I think 7 people got fired for accessing this famous person's medical information. Those things happen. So how do you protect yourself as an organization? Next slide, please.
Hold on a second, Shawn, because the cue is when Maggie comes on, I said that she was going to interrupt you. So she has a story or something she wants to tell here.
Okay,
I
cool.
don't necessarily have a story,
Honest.
although I do know who that person is that in California, and I would have lined up to give him a bad bath. Not look at his bad. My question to you is, you talk about downtime procedures. Who's responsible for that? Should your IT department be, dictating your downtime procedures?
Well, since that's coming from an IT person, I think I know the answer. So I think one of the things that's really important is that nothing is just an IT issue. Okay. There is nothing that is just, I used to love it when I'd have vendors come in and they'd say, well, we're going to have you put in this system. And by the way, there's no IT resources needed. That was always a lie. And the other thing is, IT needs to be involved, but they really probably shouldn't be owning it. It's sort of like saying, well, the light bulb went out, I better call my power company. It's like, I understand they're part of the chain, but they're not the one mainly responsible for that part. Your downtime procedures can be supported by IT, but they really have to be understood by the clinical people who will be executing on those. And that's important, because just like a system never goes in just with IT involved, I sure hope not, a system never runs into trouble with just IT involved, because that's not the right way for this to be done. Clinical people should drive clinical processes with IT support.
Absolutely. Thanks.
Good to know I answered that right, according to Maggie, because she'd call me on that one. But yeah, I always used to love there's no IT resources involved. And it would take me, 700 IT resources just to get the thing plugged in. So benefits of sharing data across systems. We talked about this some. But when we think about the role of everyone in healthcare, more and more people are getting involved in healthcare in different ways. Honestly, when I was practicing, 20 years ago, a lot of pharmacy work was, here's the prescription, count out the medicine, put it in a bottle, and the person takes it home. And now we're getting into, vaccinations, disease management, dosage adjustments, all those sort of things. And so more information is needed, and a better trained person is needed. And I think, pharmacies have shown during the pandemic how they have stepped into that role and been real cornerstones of care. But also we're seeing these value-based payment structures, and value-based payment structures, whether they're to primary care people, whether they are to, providers, whether they're to pharmacists, whoever it is, very often there's some risk that goes along with that. And before you take risks, you're going to want to have information. And so I think that as we look to the benefits of this, if a person can do their job better when they have the right information at the right time, they don't need all this extra information. They don't need just a little sliver of it. They need the right amount. And sometimes that right amount is something like, catching polypharmacy or overprescribing. I classically share the story of somebody who I had as a patient. And the week that we turned on the connection to all the pharmacies in my community, I discovered that this person, who was a fairly prominent person, was abusing a medication. They were getting a prescription from me and a prescription from this other doctor and a prescription from this other provider and all this sort of stuff. And you didn't know that before the systems got connected. And so that's part of what I mean, how do you handle that? If you're about to dispense medication and you look and the person has had this medication from 4 other providers and they have 6 bottles of it at home and those sort of things, how do you address that? How do you train your people to address that? And how do you make sure that they're not getting, 16 medicines that all contain acetaminophen or something like that? I think that those having a complete drug list and looking for interactions and making sure that you're not putting the person who's on a blood thinner, some medication that's going to make them weak and dizzy, and those sort of things are all the classic things that we think about. And as the risk gets pushed to providers and to organizations and they get more information, you have a fuller picture of things that you didn't see before. And that creates its own benefits and its own challenges that you have to be prepared to address. So it's not just about plugging the new machine into the old machine and they suddenly talk to each other. It's what about all the information and all the things that you have learned in that moment. Next slide, please. So when we talk about types of data healthcare organizations access, I mean, this is everything from your name and your date of birth to your phone numbers and your addresses. And now when we talk about social determinants of health, where you live, maybe the neighborhood that you're in, the zip code that you're in, the risks associated with it. Do you live right next to an interstate where there's particulates that are going to flare up your asthma? Or do you have hay fever and suddenly you moved to an idyllic little cabin in the woods that is hay fever central or something like that? There's also all of your allergies, your diagnoses, and some diagnoses have more challenges associated with them than others. Your medical history, how much do you need to know to really care for somebody? And how do you get in trouble if you don't know enough? The assessments, I've seen pharmacies where they're doing symptom assessments or disease assessments on people. And traditionally they wouldn't have that information. What system does that go into? And how do you connect it back to their primary care provider or people who are delivering care on them? And depending upon where you are, certain people have the chance to adjust medications or those sort of things. I mean, we're talking a little bit about pharmacy here because this was presented originally to a pharmacy conference, but this applies to everybody. I mean, we do health utilization management where maybe you have their problem list and maybe you only have a partial problem list. Maybe they have some mental health issues which are not on their regular problem list. So maybe your pharmacy actually knows something about you that your primary care doctor doesn't because of how things are connected. And the claims data, insurance claims have tons of information, not all of which is right, by the way. And one of the examples that I give is that when we were looking for diabetics as part of an accountable care organization that I was in, we ran claims information looking for people who had ever had an encounter where diabetes was coded. And what we found is a lot of doctors were miscoding diabetes for a lab test to rule out diabetes. So they were running a test to see if somebody had diabetes, and on the coding they said they have diabetes, so we're running this test. And then the test was negative. So they didn't have diabetes, but now they were labeled as having diabetes according to the claims data. And if you thought they had diabetes and you sit down with somebody and say, "Oh, I see here it says you have diabetes," and they go, "No, I don't." What do you do in that moment? How do you handle that data? Credit cards, how do you secure credit card information? How do you make sure that it's right? I mean, I remember the old days when you used to have a little machine that you had to stamp the credit card and those sort of things. And now how do you worry about credit card abuse and credit card fraud? And then there's the emails and texts. If your customer sends you a text about, "Hey, I think I need to adjust my diabetes medication," does that go in the medical record? Who do you communicate that to? How do you secure that? Is that even covered in your patient information policies that you have them sign when they become your customer? Let alone if you have a patient portal or some sort of app that they have connected into their health system. Electronic medical records were supposed to give you access to all of your information, but that doesn't mean you know what to do with it. So years ago, I used to have patients come into my office and they would bring like a big stack of records. And they're like, "Well, I went to the Mayo Clinic and they ran 6 days worth of tests on me. And here's all the results." And I would look at that stack and I'd say, "I don't want that whole stack of information." I would look at it and I'd pick 2 or 3 things out of it. Well, these days, you don't always get to say what information is given to you, but you need to know what you're going to do with it if somebody does give it to you. And all of these things have different meanings and different risks associated with them. And sometimes it's not just one of these, it's 3 of these together and all of a sudden you can tell everything about somebody, or you've opened a door to where, every once in a while we see somebody in a healthcare organization who gets arrested because they were taking patient information and opening credit cards in people's names or those sort of things. So you really have to think about who you have working in your organization. What data do they have access to? Do you have all the rules covered to make sure that you're doing the right things with it? Next slide, unless Lisa's jumping in with something here.
I am jumping in because something that I'm reminded of is a case of what do you do with deceased patients' data?
Yeah.
Because I've definitely heard of that. And the family of a deceased may not be thinking of protecting their data that's coming from the hospital. Maggie or Shawn, either one of you have any thoughts on that? Because I feel like that could be such an easy miss in the throes of that. And, especially, this is a much more morbid situation, but if that deceased is a child who may not even have a credit history or anything like that too.
Well, you threw me off with the child thing, but since Maggie Maggie unmuted, I'm going to throw this over to her as the system CIO master here.
I'm going to weigh in that you cannot get rid of patient data once you have it. Pretty much, you have an order to maintain it and to respect it. But I'm going to give a little different twist, and I'm going away from patients right now. A lot of systems are based on, and I'm shocked at how many examples Shawn is giving that I've experienced in my own past. But one of the systems that I put in, for example, in order for a physician to get access, his credentialing information needed to be up to date, and that's what allowed him to have access into our system. But their offices would never tell us, when the physician changed practices or changed offices, let alone if he died. So you would have a physician who had access to your system. Now you still had the expiration of passwords, et cetera, but there's a need to update the data and who holds your data that you don't often think about. From a URAC perspective, for example, when we migrated to AccreditNet 3, we migrated all the contacts from the organizations over to AccreditNet 3. Do you realize how many contacts have once upon a time been associated with your organization? And we've never removed them because we didn't know they left your organization, but they're still there. So think about who holds your data and where is it held?
And I really appreciate you teeing up this next slide there, Maggie. Thank you very much.
Welcome.
So who's accessing? So there is identified data. Identified data is data that can be tied to a particular person. Okay. And that's generally, your staff, other groups such as pharmacies or other people within the healthcare landscape, hospitals, health systems. These are all the people who you do business associate agreements with, and you make sure that they sign all the forms and all those sort of things. So they can access identifiable data. Now, de-identified data is where we go, there's a person and they've got some condition, but we're not given enough to really know exactly who it is. And that's like the manufacturers, in case there's a recall or something like that, or URAC. When we come in and we do an accreditation, we do not want your patient identifiable data. Let me repeat, we do not want your patient identifiable data. And actually in our agreements that we sign with you, we say, don't send that stuff because that's just icky and sticky and we don't want to deal with it. Okay. But then we also talk about reporting measures. And when you report measures to us, the data validators who come in are supposed to deal with de-identified data. So where we know how you're doing with treating your diabetics, but we don't want a list of all of your diabetics or anything like that as we go through this process. And then there's the state and community health agencies, there's requirements for reporting certain information depending upon where you are within the whole healthcare landscape. And I always remember, if somebody came in and they had some sort of special disease that was reportable, we had to report to health agencies just sort of at a high level, and then sometimes they would investigate and those sort of things. But it just depends upon the data. And if you're going to touch anything that looks like protected health information, you need to know the rules as they apply to your organization. You need to know how you can get into trouble and how you can avoid getting into trouble. Next slide. And I get to turn it back over to Maggie and disappear for a little bit.
Thank you, Shawn. Don't disappear too far. I may need you.
Okay.
As I go through these slides, you may see some starred items on the slide, and I want to point those out because they are actually part of the URAC standards. So I'll point them out or I'll call them out as much as possible when I go through them. But what you need to know is there are a number of risk factors to be mitigated. Now, this is not going to be an end-all be-all of everything that is to do with technology. First of all, I'm not qualified to do the end all be all. Remember, I have RN after my name. Yes, I am CIO, but you could spend days on just risk factors and mitigation of risk factors. We are also very aware of URAC that our clients range from huge multi-site conglomerates with multiple departments and tons of technical resources to very small organizations with much less staff and very few resources, or they outsource their technology resources. But the bottom line is you're still entrusted with this client data, and you need to guard it from both a security and a privacy perspective. Especially with the nature of current cyber crime, we are past the, for example, my brother's a physician, and he used to have a little office in a little area, a little town in Pennsylvania, and he had an office management system. And guess who his IT person was for the office management system? It was me. We are well beyond my brother-in-law, Joe, taking care of my system. You really need to think about these things when you've got this level of data entrusted to you. Things to be aware of: physical, how are you backing up your system? What technology precautions are you taking in? Malware, we could spend days on malware. What kind of systems do you even have? Social engineering fraud. What phishing attempts are your staff facing on a day-to-day basis? And I'll give you some examples because some of our clients have been hit by phishing. Business interruption from system failure. You are more and more reliant on all this data that you're getting in and processing, and that's how you do your workflows, and it's how you keep your lights on and do your business. What do you do in the case of downtime? And you can't look to IT because IT doesn't really understand what you do. So they can get your system back up for you, but they can't tell you what to do while you're down to keep your lights on. Breaches in privacy. The costs of notifying customers who have had their data breached, or the cost of providing credit monitoring services, an example, very expensive. And then there's the overall business breaches: stealing your secret sauce, stealing other kinds of information that you have. Finally, there's ransomware. Your entire system could be locked down so that you can't access it, and you have to pay some huge fee in order to get the rights back to your own system and your own data. In terms of threats, ransomware is huge on the landscape, and you need to be aware that there's been a shift to what they call BEC, business email compromise. These threat actors, and these actors, there could be corporations that are just corporations focused on ransomware and attacking you. They are finding a lot of success by coming in through a phishing attack, then compromising an account of one of your employees, and then stepping in as a middleman in a conversation, pretending to be that employee, and sending out fake invoices, asking people to send money to fake bank accounts or send a fake wire transfer, having some sort of system in place that's going to help you and your employees identify those kinds of threats, and maybe sandbox links when they're opened up by your employees. If it's a bad link, those can go a long way. In addition, you need a non-technical workflow. Pick up the telephone. If you get an email from one of your employees into payroll and it says, hey, could you take this week's pay and put it in this bank instead of the bank I have on file? Pick up the telephone and validate that was really sent by the employee. I can tell you personally that I have received emails from a client, one of their CFOs, as a matter of fact, asking us to wire money. It was so close. The email address was the same email address off by one letter. The phone number embedded in it was this person's phone number off by one number. And if you wrote back to that, there was a threat actor who pretended to be that person and answered that email almost instantly. That's pretty much how I knew it was fake, because nobody answers their email that quickly. Also, in terms of supply chain, when you're bringing in a new system to your organization, what are you doing with regard to evaluating that system from a cybersecurity perspective? Are your vendors vetted for SOC 2 or some other sort of security verification or accreditation or certification, ensuring that they are looking at the risks their system has and mitigating the vulnerabilities that are found. Also, you need to be aware of it because then you can react. For example, there was recently a vulnerability with a security, with a technical service called Logic4j. And it's something that software developers invoke to keep an audit trail within their software of people who are accessing whatever. So it's embedded in software. When Logic4j's vulnerability was identified, URAC was able to identify what hardware and what software was at risk so that we could shut it down or we could mitigate the problem until the entire vulnerability was remediated. So you or your technical team needs to be on top of these things. Next slide, please. Okay, physical risk. So you see our first star. Minimize the number of people who have access. Minimize the number of people who have access to what? To data, to your servers. You know, Shawn doesn't have access to our server room, even though he's the CEO. Not so happy about that. But do I have a process in place in case Shawn needs to get into that server room? Yes, there's a way he can gain access, but he doesn't on a regular basis have that access. Also, you want to make sure that whoever is accessing the data has just the amount of data they need to do their jobs. That's called role-based security. And you want to make sure you have roles identified for your staff and that the amount of data they see is based on their role or a need to know. It's helpful if you have access to your computer room for your server room through a fob, for example, if you have some sort of audit trail, so you know who went in and out of that door. On our computer room, we have, if the door gets propped open for whatever reason, the air conditioner guy's coming in, we get a call from a security agency that's monitoring our door and says, hey, your door's propped, so that we can react to that or let them know that we're aware of it. In the server room.
Maggie, I can't believe you brought up this painful point of the fact that I don't have access to the server room.
No, I'm so
you know that's bothered me for years. Okay.
I know. Hey, let me tell you, I come from a place where when a departmental system came in and we didn't shut down access to these server rooms, they would not tell IT that they were buying a departmental system. That was beside the point. They'd let them into the server room and the departmental system guys would start unplugging regular systems so that the port, I need a port, I'll unplug whatever there and I'll plug into that port. And instantly the entire HIS is going down for that floor. You have to be aware of who's in and where.
Okay, okay, I feel better about it now. All right, I'll go away.
Thank you. Uninterruptible power supplies, are they in place? Do you have air conditioning in your server room? You don't want those things to overheat. I have a fob lock on my door. I also have a set of keys because I don't trust that that fob lock is going to work forever and that the batteries are never going to die. But I do trust a metal key that will go in a lock and unlock it. So those are the kind of things you want to think about. Don't get caught up in the technology solves everything. Go back to the basics. Next slide, please. All right, another star. Test your systems regularly. You back up your systems. You're sure they're backed up and you've got downtime procedures. You ever tested them? Are you sure they're going to work? You might have tapes upon tapes, but have you ever actually stuck them back onto the system to make sure you can recoup the data you had? If you don't do that, then your backup are really worthless. You also need to be aware of, is the system an on-prem system? Meaning, is it on premise? Do you have a server that's running your system or is it out there in the cloud? A lot of people think that cloud-based systems are automatically backed up and I don't have to worry about them. And that's not true. URAC, for example, has Office 365. All of our Office stuff, our Outlook, our Visio, it's in the cloud, but we have it backed up. Our SharePoint, our OneDrive, our mail is all backed up because if something happens, we can still get to our data. You also want to have layers of backup, both out on-site, off-site, and what they call air-gapped backup. An air-gap backup means that there is some sort of separation, either logical or physical, between the data and the system that the data is for. So think of a disk, for example. if you have a hard disk in your hand or a file or a floppy, no, floppy drive, I'm dating myself, but if you have a tape backup, for example, that's different than the system. Or you might have it virtual. It might be with an organization. In order to get access to that data where it's backed up, your administrator needs to validate, authenticate who they are in order to get access to the data. The reason you do that is because if your system becomes corrupted, you want to be able to get back to a clean piece of data so that you can restore your system, and you're not just restoring your system with corrupted data. And then finally, you should have recovery plan for each system with recovery time objectives. That's really going to point to what are your critical systems. What systems can you tolerate being without for 24 hours or 4 hours or 48 hours? That's going to tell you how much risk you need to mitigate and what you're going to put in place to keep the lights on. And then also recovery point objectives. Where do you want to recover to back as a point in time?
Maggie, I'm going to ask you two questions. One,
Sure.
whose responsibility does this fall to? And my second question is, how do you make sure, I mean, I'm thinking a little bit about training younger staff. And I remember at some point working for a different organization, and one day our server was down. We couldn't do anything.
Mhm.
And they were like, well, we can't do anything. And I was like, no, let's think about what we can do in the downtime to be productive too, because for any organization, you're thinking about dollars and what's being spent. So how do we kind of, who does this all fall to? Is it everybody needs to be aware? Where does it
It's
fall?
in everybody, Lisa. I have to really be honest with you. It's in everybody. Let me give you an example. I was with an organization. We didn't have access to our internet, but we had a lot of on-premise systems. So for the most part, we were humming along. Patients were getting taken care of because our major health information system was on-prem. Except I got a call at about 8 o'clock at night from a director of nursing for one of our little nursing homes that I didn't even take care of. I didn't know anything about. Their medication delivery system was in the cloud. And she was like, what do I do? I can't get access to it. And I said, well, you'll have to go to your downtime procedures. I don't have any downtime procedures. She had no idea what meds her patients needed, when the last time they got those medication was, when they were due again. That is just a frightening situation to be in. And I, as an IT person, can't tell her what to do for her own systems. There's ownership on both sides. Your technical people need to make sure the backups are happening, make sure that the systems are getting patched, all of that stuff. But the department, especially the department that is critically based on that system, needs to know what to do when that system is unavailable and what they can still do to keep the lights on and keep the work going. Next slide. Okay, there's a lot of stars on this one. This talks about encryption of your data. And when I say encryption, I mean not only data at rest, sitting on a disk, sitting in your system, it's encrypted. I mean in transit. It's going through wherever, between whatever systems, is it encrypted so that if somebody were able to get into the middle of that, do they still not have access to your data? You want to make sure you have role-based security. There are clear roles for everyone who has access to the data, and they only get the data they need to do their jobs. You want to conduct regular risk assessments, and you want to have a business continuity plan that is tested at least annually. When you bring a new system in, you should be doing an evaluation of that new system. Access, passwords and logins are no longer just the base, are no longer needed or what you want to hang your hat on for a system. You want to have multi-factor authentication or single sign-on, especially if that data is of importance, contains PHI, PII, or PCI. At URAC, we still have multi-factor authentication in place. We still have single sign-on for a number of our systems, even though the data we're getting from our clients does not contain PHI, PII, or PCI. In fact, we don't want it, and you would be ticked off, you'd be marked off a little bit in your accreditation if you were to give it to us. But we still are trying to keep control over all of the systems that are in our purview and all the data that we are granted by virtue of the accreditation process.
Maggie, just as a note here, I just checked in with our reviewer, Heidi, who's on the webinar with us, and she confirmed with me all of these that we have starred here, they are all in our foundational focus areas or core, whichever version you're in as a URAC client. This is important for every single one of our programs. We ask this whether you are utilization management, pharmacy, or a health plan. So just so you know, it's in there, and you may not know the answer, but as we always say, as we're preparing clients for accreditation, make sure somebody in your organization knows the answer and can help you submit the right documentation to show that you're doing these things.
All right, let's go to the next slide. Let's talk just a little about what malware and ransomware is doing to us these days. Shawn was right. Cybersecurity insurance has skyrocketed. If you can get cybersecurity, if you've ever gotten hit with an incident, oh my goodness, your cybersecurity is probably tripled in price. For us who have never gotten hit, it's still increased and doubled in price. What are you doing? And your least common denominator is staff, because remember, I talked about they're getting hit with these phishing emails. How are your staff equipped to identify that this email is phishing? I had one client who said, can you please brand any email coming from URAC with something that says URAC, so I'm sure it is coming from URAC? Well, that's nice. And yes, we should. And we should identify ourselves as URAC, but don't rest your laurels on the fact that it says URAC somewhere, or that it has the URAC star or the URAC seal. It's very easy to go onto any website, steal that, paste it into an email, and pretend you are from URAC. So your staff should be aware of how to identify a phishing scam or a phishing email. At URAC, for example, we test our staff on a monthly basis, and I have to report metrics. I'm being held accountable to my staff for how the staff are doing and whether or not they're reacting appropriately to phishing emails. We also have training annually. If you were to fail one of those tests, you get invited to take a little training session on phishing and how to identify it in the future. So again, it's very, very important. It should happen with your staff. It's not just the responsibility of the technical people. You can put things in place, but it's everybody's responsibility, Lisa. Okay, next slide. All right, finally, what kinds of systems do you have? So this talks about custom systems versus out of the box. And even whenever you're in an organization, there are often things that happen that you just can't buy something off the shelf for. So somebody's developing it within your organization. It's important that your technology department, that developer, is following best practices for security standards. Out of the box systems, you want to make sure that the license agreements you hold have special provisions in them that are guarding against whether or not that system is compromised. You want to make sure before you sign a license agreement that you brought in legal and that they're reviewing those license agreements with you. It's very important that you know, is the system physically in your control or is it out in the cloud somewhere? And like most organizations, you probably have a bit of both. You have systems on premise and you have them out in the cloud. And what do you have to do for the security challenge of each one of those types of systems? And especially if you're bringing in a brand new system, IT should be aware whenever a new system is coming in the door. So an evaluation can be done of every new system. They're aware of what they've got and they're aware of what kind of data it holds and what kind of access is used to allow access to that system so that they can invoke the highest level of security possible. So I could spend days on this, but I'm not gonna. I'm gonna hand off to Shawn now, who's gonna talk about how policy fits into all this.
And I just want to give a piece of feedback. I want you to know that training that you have to take when you fall for the phishing email, it's really a lot of fun to take because I've gotten to do that just to share that. And also when we recently had somebody join our leadership team and they received a phishing text purportedly from me, and they had my number. I mean, it did not come from my number, but there was somebody on there saying, hey, this is Shawn, can you do me a favor and go get a Google Play credit card and send me? It's like, Okay, luckily they knew enough to go, that's not Shawn. But let's talk about how policy fits in as I sit here in Washington, D.C. Next slide, please. Interoperability. The 21st Century CARES Act requirement for interoperability means you have to connect your system with other systems. And there's this thing called the Pharmacist e-care plan, and it's about connecting things and having a standardized format of the plan. And there's actually fines for non-compliance on interoperability. So the government is saying you have to find a way to connect your system. So the government is saying you have to find a way to be more vulnerable to these sort of connections. So you have to figure this out. You can't just sit in your little box and say, I'm not going to play with anybody else on the playground for fear I'm going to catch a virus. You need to have your, that's one of the reasons why we say that you probably want to not have a homegrown system if you can help it, because the bigger systems generally have more people involved in security. And the time for really trusting your IT support to your son-in-law or your daughter-in-law or your neighbor's 8-year-old is probably past at this point. You're just inviting trouble. When I was a family practice doctor, I used to say, I need to know what I know and I need to know what I don't know. And if you don't have the technical skills to where you want to battle the foreign agents trying to hack into your system, don't do that. That's just not a good idea. Next slide, please. So the ultimate goal, have a more complete picture of the patient to provide better care. That is a great thing. Having more information as appropriate is a good thing, but you got to have the tools to understand the new risks to your business when you connect systems together and when you have more information. Sadly enough, most of the time, the biggest risk in any organization are the people sitting at the keyboard and the people clicking things they shouldn't. Data security is constantly under attack. You need to know, can you do it, or do you need somebody else to help you do it? There are serious legal implications and monetary fines if you mess this up. So like I said, it's great to have more information, but if you're going to do it, you might need a life vest if you're going to jump into this pool. And if you don't know how to make life vests, don't rely on your own homemade life vest on this one. Know what you know and admit what you don't. And next slide. I picked this up at the end just because I saw that we were running out of time. We really want you to know, number one, don't send us health information. That's not what we want. And we will be upset if you do it. We tell you not to do it. So please don't do that. And as we go through this process, we just want you to know that there are risks out there. We want you to be prepared for them. And accreditation goes through some standards that help you be better prepared for the risk. And we do that because we work with thousands of organizations all over the country, and we see the mistakes that are made and we update our standards to try and protect you. One of my definitions of wisdom is learning from other people's mistakes before you make those mistakes. And that's what we're trying to do with our standards at URAC. We're not trying to be mean or bad. We're trying to protect you when you're going through a neighborhood that's got some risks. And I see Lisa's jumped back on to
Shawn, I love this question from Tracy in here because she's interested in knowing about texting. Because many patients want to text. I'm of that cohort that like, please text me. Please don't call me. Text me. She said, is a patient signing off on a waiver enough to allow texting of PHI? And I think we're going to see more of that.
So most texting is not secure enough to where I'm a big fan of PHI being involved. Your mileage may vary. You should have a really good lawyer who reviews any agreements that you have patients sign regarding health information. Now, Maggie may have a better update on this because I left the hospital world. Texting was driving us crazy back in 2016 and 2017. Maggie, how would you answer this question? Oh, great, wise one.
I would be very similar. I believe there are some proclaimed secure texting solutions that you need to invoke. But they're not just your usual Messenger Plus or Plus. Yeah. So if you're going to allow this, bring legal in, make sure you brought in IT to evaluate these systems. And I would be very wary of allowing texting.
And I would also say that during the pandemic, some of the HIPAA risks were dialed down because there was such a need for communication and connection to go on during that. When the public health emergency ends, which it will eventually have to end, HIPAA comes back. And as I've joked before, I said every organization needs to have a hypochondriac, somebody who's afraid of HIPAA violations and they view everything from a risk standpoint. But texting in general is not a good idea for PHI. It's also just not a secure platform. So have a secure platform where somebody who does this a lot more knows what's going on before you ever consider doing it, and then have the lawyers involved, because it's just getting you into trouble.
Shawn, you brought up the public health emergency. And with that, I know you've done full talks on telehealth platforms. We have 2 minutes left. Let's spend it on telehealth platform security there, because that's another element and it's huge.
So during the pandemic, a lot of organizations stood up telehealth platforms. Some of them built their own. Some of them were using, Zoom like we are now. Some of them were using, Apple Messenger and that sort of stuff. During the pandemic, because the need for delivering care was so important, the federal government said, we're going to assume you're not trying to violate HIPAA, and we're not going to smack you for making little mistakes. Well, they used to smack for little mistakes, and that was one of the reasons why telehealth didn't pick up that much. When it comes to vendors for telehealth platforms, go with a good one, go with a big name. And if you look at a lot of the big name vendors, they've gone through URAC accreditation. And just like we check a pharmacy or we check a health utilization management company to make sure that they're protecting their data, we also do the same thing with our telehealth accreditations. So expect us, if you see a URAC accredited vendor, they jump through the same hoops that we're expecting you to jump through. And that's part of what is safe. There's a lot of vendors out there who aren't going to be there in 2 years. Don't invest your 401k all in one company's stock just because of that, and be suspicious because of the risks involved in doing that.
I see a big question here, and I'm going to ask either Shawn or Maggie to give the kind of short answer, and we'll follow up with you with a message from one of our reviewers with the longer answer. But during our validation review, key part of URAC's process, URAC audit may include reviewing patient file cases. But what's our just general 1 or 2 sentence overview?
We're reviewing through WebEx, which is a HIPAA compliant web interaction. We don't do it through Zoom. We don't do it through Teams. We're using WebEx because it is HIPAA compliant. If a client doesn't want to use WebEx, we ask them to do an attestation to tell us, they're taking the onus of that HIPAA security. We don't want your files. We may look at them to validate them, but we don't want them.
And accreditation usage, exposure to protected health information is a covered thing that can be done for quality improvement. And it's allowable, but we still want to do it in a secure manner. But we don't take a bunch of copies and leave with them, because we don't want to do that.
We don't want to do that.
Maggie and Shawn, thank you. This was a really great webinar. I think we could do this topic 4 times over and cover just even more and more material here. For those people who may not have attended one of our past telehealth webinars, we do cover some more of this as relates to telehealth in depth. We'll also send a follow-up email. Thank you for attending, with a link to the recording and the slides. So be on the lookout for that as well. Thank you so much, everyone. The evaluation is going to pop up on your screen as soon as we end the webinar.